This is going to be a very oversimplified talk in many ways because it will be best received by people who are just beginning to think about looking at patients and interpreting physical characteristics, or people who aren't even interested in that but would like to have more fun when they go to the mall. Looking at those very interesting people going back and forth. As a dysmorphologist, I'm seeing my specialty dissipate as we develop more and more laboratory tests to make diagnoses, and in many instances, diagnoses that I haven't made, or ones that I thought I knew that are so variable based on these new tests that I wouldn't even recognize in some instances the same syndrome I reported many years ago. But I'd like to give you a sort of a little format of how to think about things that you see in photographs or at the meetings or the bedside or when someone brings a sample to the lab to sort of visualize what this might represent. Now, if you're a clinician, particularly a dysmorphologist, this is where you spend a large percentage of your time. In the dark, cold, rainy. No Dick's Lake is no diagnosis. And we don't like that. It used to be that at least a third of the patients I would see, I couldn't diagnose. And as time went on and I got sent more difficult patients, that percentage went up to 50%. And now with all the testing that people do prior to sending me their patient, it can go as high as 75%. And so it's getting harder and harder for the man on the front lines to make a clinical diagnosis when they're getting referrals of very difficult patients. It used to be a feather in your cap if you could consistently and securely diagnose Down syndrome. Well, nobody even thinks about that anymore. Even though they still miss the diagnosis, they can have a quick test if it's even in the differential and not have to worry about it. But I worry about it because the things that we recognize can allow for diagnosis immediately and doesn't require initially a laboratory test and a period of waiting before the family is told what the patient has. Now, when I look at a face, I look at it because it's very useful. It's very complex, but the pattern it forms is very diagnostic in many syndromes. So we love to see patients who have multiple anomalies with a characteristic or unique face, because that gives us the clues. But if you don't recognize the face, and you can't put the pattern with the other abnormalities, then it's difficult to make a diagnosis. So recognizing the pattern of the face and putting it into a particular gestalt can be extremely helpful, particularly when you're searching for comparable patients. Each of these sections of the face have their own unique features, and abnormalities in one area frequently result in abnormalities in other areas, and thus a pattern starts to form. You can have secondary facial abnormalities. It's still a pattern, it's still useful, or you can have a group of primary abnormalities, and I'll explain the difference as we go along. But think of the face in pieces, and then you can reconstitute it once you've picked out what you think is abnormal. And remember, the variability of normal individuals is unbelievable. So you don't want to isolate the patient away from their siblings or their parents, or if you have the option, further remove relatives to see what their normal features are, so you can exclude those from what you're seeing in the patient, or in some cases include them as part of the syndrome. Here's a group of patients that have very characteristic faces. Most of these can be diagnosed immediately at the bedside after a good clinical diagnosis, even though a lot of us walk in and we gestalt and we immediately make a diagnosis, like in 2 seconds. Well, that's not good, but the more experience you've had, it's not as bad as if you don't have a lot of experience, because you make conclusions that really, in the long run, don't fit. And you've heard the word phenocopies, individuals who look like they have the same thing but don't. I won't go into these in great detail, except that each one of them, if you put that face that I showed you all the different sections, have abnormalities in one or more of those sections. Now, what is an anomaly? It's a basic alteration in the structure of a body part, usually before the 8th or 10th fetal week. So it's an intrinsic, primary abnormality of a developing structure. Examples of that would be a cleft lip, phocomelia, which is the attachment of the hands and or feet to the proximal portion of the body, and anencephaly. Here's an individual with anencephaly. This is a posterior anencephaly. Many times you'll have missing CNS or brain more anterior. But you can see that there's some secondary effects. Look at the ears. They're usually low set. They haven't had a chance to develop. They've been crowded. And so they're often simple and small. The neck is often short because the vertebrae of the cervical spine are frequently abnormal. Here you see a patient with a unilateral cleft lip, and in this case cleft palate. That distorts the face in many ways, makes it asymmetric, can obviously affect the palatal configuration. And 1/3 of all patients with clefting are going to have other anomalies elsewhere, and so they will become syndromic. And so you always look carefully for other abnormalities, and in particular you look for head size, head configuration, to make sure there's no immediate indication of central nervous system problems, because you can tell a family, well, your child has a cleft lip, we can repair that, everything's going to be okay. And then the next day you come back after someone else has found some other features and say, well, we were wrong there, your child's going to have severe mental problems and maybe seizures, et cetera, et cetera. So things that look simple are not unless you look very carefully for potentially associated abnormalities. And here's a patient with phocomelia with the feet attached to the hip area and the arms were attached to the shoulder area. These are structural defects occurring fairly early in gestation, and they're primary anomalies. What's a deformation? And I like to use the word secondary effect. It's a compression or biomechanical distortion of an already normally formed body part, which usually occurs after 8 or 10 weeks, fetal weeks. It can occur before that, but it's often after that. Examples of that would be club feet, plagiocephaly or asymmetric skull. I'll show you a picture of that in a minute. A neck that's been off to the side, or torticollis or wide neck. Contractures, or in some cases arthrogryposis, dimples of the skin, and joint dislocations. Here's a patient with arthrogryposis of a generalized variety. In some of these cases, everything you see in this patient is secondary. The central nervous system or the cord lesions or problems affected movement in utero, and if a joint doesn't move in utero, by the 4th or 5th month, it becomes frozen in that position and stays that way. You can see that the feet are involved, club feet, the hands are flexed, the muscle mass is decreased. Many patients with arthrogryposis will have a definable reason for it, but some are not at this point diagnosable, and because the defects occur and cause in unison contractures of the arms and legs and decreased muscle mass, you may not get much more in the way of physical features to help you make the diagnosis. Plagiocephaly, this is the right forehead, this is the left occiput. This child was in some intrauterine position. Maybe the mother had bifid uterus, and the baby didn't have as much space. Maybe the baby was up under the mother's diaphragm and was locked in there for an extended period of time, and so the head was forced to grow in the line of least resistance. So plagiocephaly is often secondary, and frequently patients with plagiocephaly will also have scoliosis because the spine is connected to the brain and the skull, and if there's asymmetry there, there's frequently abnormal movement and positioning of the spine. Here you see a dimple on a leg. This is the lower leg, and the dimple's here. You can see an abnormal crease here. It really shouldn't be here. Dimples occur when the skin is closer to the bone than it normally is, and it becomes bound down. This is more common at the joint areas where you see dimples. In little babies, they frequently go away, and the dimples are there because of the fat tissue, the extra fat tissue that newborn babies have. But if they don't go away, there is a pathological reason in many instances for that. This is a curvature of a short tibia, and that has forced the skin, in this case, to a medial crease. Sometimes these creases can go all the way around, depending on the degree of severity. And as a secondary result of that, there's a deformation or a club foot. A disruption is a little bit harder to understand, but it's important to know that it is a descriptor that has usefulness. It's a compression or biomechanical distortion of an already formed or to be formed normal body part to such an extreme that the resulting defect looks like an anomaly or a primary defect. So you come in and you see a patient with 10 major features. One of the things you want to do is decide, well, what's primary, what's a deformation, and what is a disruption. And that helps you weigh those particular features. Examples would be oligodactyly due to amniotic bands. The hands are more often than not normally formed before the bands become entangled in the fingers or the toes or the legs, and then there's a constriction, and you can get amputation, you can get fusions, you can get syndactyly, you can get a lot of secondary features which would be called a disruption. Cleft palate due to glossoptosis. We'll show you some pictures of a patient with Pierre Robin. The only primary abnormality in Pierre Robin is a hypoplastic, severely hypoplastic lower jaw or mandible. If that's present early in gestation, the tongue cannot sit on that area without falling back due to gravity into the posterior throat, and that blocks closure of the palatal shelf, so you end up with a large cleft palate. And the cleft palate in that particular situation would be a disruption, not a primary anomaly, even though under most circumstances we would call it a primary anomaly. Webbed neck due to edema or swelling in the neck area is another good example. Here's a child with Pierre Robin. See the very small mandible. And when this child was younger, you can see how hypoplastic it was. Excuse me. Oops. Okay. I've lost the slide anyhow. There it is. Okay. It falls posteriorly into the back of the throat and won't allow the normally separated palatal shelves to close. Any child who has a small, severely small mandible is going to have low-set ears. So the low-set ears, which is another major feature of Pierre Robin anomaly or sequence, is a secondary defect or deformation. Here you see an amniotic band individual. This is a child of a cardiologist from the University of Kentucky who was born with these ring constrictions, amputations of distal portions of the fingers, and a hallux that was there that was torn off basically in early fetal development and transposed to this position. Webbed neck is another secondary effect. Here's a child with Noonan syndrome. who has a webbed neck and what they often call a low hairline, but most webbed necks don't have true, don't have true shortening of the neck. It just looks short because the web, or the skin, rather than coming this way, is pulled tightly this way. It brings the hairline down artificially in your eyes, but it's not low set. The only time you truly get a low set hairline is with multiple fusions of the cervical vertebra, so the neck is short radiologically. This is it's potentially aborted Turner syndrome with the nuchal edema that caused this. Many of these children don't survive, so we don't see the severe webbing, but those that do survive still often show signs of having webbing in early utero. Oops. This is a little girl with Turner syndrome, 45X, who had the edema at one time, not to this degree, but you can still see the remnants of that may last this child's entire life. This is not a individual with webbed neck, but when the neck is short, you do get distortion of the skin, particularly if the individual is heavy, and you sometimes get these double creases. Okay, what's a major anomaly? Now, the next two things, major anomaly and minor anomaly, were originally constructed to impart whether you had a treatable, severe condition, or excuse me, a non-treatable and difficult to take care of surgically or medically condition. And then the minor anomaly is a descriptor for something that was present that could be repaired. So that's the original intent. As time went on, the intent changed a little bit to try to have the clinicians, when they're looking at a patient, say, well, this is a major anomaly. We don't know what it means, but it's important because it's severe. But it doesn't make much difference whether it's major or minor from a diagnostic standpoint. You have an increased chance of making a diagnosis whether the patient has a major or minor and multiple major or minors. It's a basic. How do I get it back? We were right there, number 12. 12. So a major anomaly is a basic alteration in embryological development severe enough to require intervention and which potentially has a long-term impact medically and or psychologically. Examples of that would be spina bifida, omphalocele, bilateral cleft lip and palate, and anophthalmia. This individual has a major anomaly of closure of the spine and has a myelomeningocele. And you will note this individual's head is quite large. This is a secondary hydrocephalus, often associated with that. It's not a primary anomaly. It develops as a effect of the opening of the spine and fluid movement. These individuals also often have club feet, which are not major anomalies, but are secondary and deformations resulting from the lack of closure of the spine and neurological deficit to the lower extremities. Here's an omphalocele. It's a very large one. Many children with omphaloceles, that's all they have, but upwards of 30 to 40% will have it on the basis of a syndrome, so you look very carefully. In addition, the omphalocele often results in GI difficulties like stenosis or atresia of the bowel, malrotation of the bowel, so they can have lots of other problems other than just getting this back into the abdomen. And here's a child who has bilateral anophthalmia. Interesting enough, most patients with bilateral anophthalmia are going to be neurologically normal. So they're just missing their eyeballs and maybe part of their optic nerves. But if you look at this child, the first thing you see is a very large head. And so you want to be very careful about prognosticating this child's situation, and need to do a number of studies to see what's causing the head to be enlarged. A minor anomaly, and we're going to start to get into some quibbling areas between minor anomalies and minor or normal variants. It doesn't make much difference because minor anomalies and normal variants often overlap and can be found in normals as well as abnormals. But you need to know the difference. Minor anomaly is a basic alteration in embryological and/or fetal development which requires no treatment or can be more or less corrected. Examples of this would be polydactyly, in this case on the little finger side, absent digital flexion creases, low set ears, preauricular tags. Here's a child whose only abnormality is polydactyly. However, when we see polydactyly, we want to know family history, because this is a dominant, so frequently you'll have family history. And you need to go back 3 or 4 generations, because polydactyly, as an isolated feature, is non-penetrant in a significant percentage of the family. So you may have siblings, parents, and even grandparents that didn't have it because it wasn't penetrant in them, and then you have great-grandparent or great-aunt or a number of other people who have polydactyly. Sorry. Just didn't like to go backwards. Yep. Sorry. We're at minor anomaly.
This one.
Or actually 15.
Okay.
Okay. And then you see in the center picture, creases that are missing, particularly on the 5th fingers in these individuals, plus incurving of the 5th finger. In the normal population, both of those features occur in a frequency of about 1 to 5%. So these individuals are totally normal otherwise. But there's a huge number of syndromes in which those 2 features can be found. So again, you want to look at other features. Now, the bottom picture is not only preauricular tags, which occur in 1 to 2% of individuals, normal individuals, but also have a high increased frequency, as you can see in this picture, of abnormally formed ears, and those ears that are abnormally formed have an increased frequency of deafness. This particular patient also had a more generalized syndrome called Goldenhar Syndrome. But preauricular tags are not necessarily an anomaly. They're either a minor variant, or in some cases, as this one, they can be a minor anomaly. Minor normal variant features. Again, we're sort of skirting around how much these overlap. But it's a low frequency, 1 to 5%, that's found in the general population as an integral part of multiple anomaly syndrome. A simian line is an example. 5th finger clinodactyly, 2-3 toe syndactyly, epicanthal folds, accessory nipples. All these can be found in normal individuals, and they can be found in abnormal individuals, and depending on how frequent this feature is in the patient you're seeing, and in the syndrome that patient represents, it can be a useful observation. The upper left-hand panel, you see a simian line, single transverse palmar crease. 2 to 5% of all normal individuals have simian lines, either unilateral or bilateral, but somewhere near 40 to 50% of Down syndrome will have a single transverse palmar crease. So in Down syndrome, it becomes not as useful, but more useful than finding it in a normal individual. The reason being is that so many syndromes that I I haven't mentioned, also have an increased frequency of sending lines. So it's an observation that you put on your checklist as you're doing your observations and physical diagnosis. The upper right-hand corner, you see a patient with 2-3 toe syndactyly. Most people don't realize that toe syndactyly is normal up to about 30% of the distance from the base of the second or third toe as you go up. Anything over that becomes abnormal. And this can be inherited as a dominant and not be part of a syndrome, or it can be an integral part of a number of syndromes. You see the right lower picture is showing you an accessory nipple. Somewhere between 10 and 11% of patients will have accessory nipples. In utero, very much higher percentage early in gestation. These represent the old mammillary line areas where nipples develop for breasts for feeding to babies. And in humans, all but the major one goes away, but not 10 to 11% of the time. And they don't all even look this significant. They may just be a very small, pale, well not pale, but slightly darker lesion with or without the nipple itself, just the areola being present. And we've seen it a number of times. It's usually not associated with syndromes, but there's a couple that it is. Simpson-Galabi-Beagle syndrome being the most significant association. However, if you find these off the mammillary line, then they can be associated with internal anomalies. So again, knowing that can help you look at other possibilities as far as complications. And then on the right is a dimple here called an acromial dimple. Many individuals have these, women more frequently. It can be inherited as a dominant. Individuals who have reduced muscle mass of the shoulders and neck area, this is a common secondary effect because, again, the skin is closer to the bone than it normally is. This can be unilateral or bilateral. My comments on anomalies is that most malformation syndromes have more minor or normal variant type of anomalies than major anomalies. That doesn't mean that the major anomalies aren't important, but that you need to pay attention to the minor ones because they may give you the patterning you need to make the diagnosis or suspect a particular diagnosis in your differential. Down syndrome is probably one of the best examples of a condition in which there's a huge number of physical features. Most of them are going to be minor anomalies or minor variants in the otherwise normal population, but the patterning is so distinct in the face and as far as the other areas that you can use all these to make your diagnosis. Here's a collage of individuals with Down syndrome. The epicanthal folds are found in 25% of normal newborns and dissipate as the nasal bridge grows until the normal population by adulthood has about a 3 to 4% frequency of epicanthal folds. But in Down syndrome, it's 50%. So the difference in the percentage that a defect is present makes it more important, even though it's a minor variant or a minor anomaly. The flat nasal bridge is something that a lot of newborn babies have. The small ears can be found as normals in the normal population. The most useful feature besides the facial gestalt is the very high frequency of hypotonia. And if you're making or suspecting a Down syndrome and he or she's not hypotonic, you better really look at that patient very carefully. And there's ways to test hypotonia other than just looking and picking the baby up. Multiple congenital anomalies is a category where we have multiple anomalies in one patient. These may be primary or secondary or a mixture, and they are usually in different body areas. Although the face being so complex, you can have major anomalies of the face unrelated to each other but caused by the same genetic defect that helps you make a diagnosis. They're usually associated with a potentially recognizable syndrome. Many years ago, I collected all the patients I'd seen with known and unknown syndromes, but in this case, known syndromes, and defined how many had a known etiology. This was in about 1978. And about 50% of those patients, not only could you recognize the phenotype, but they had a definable genetic cause or cause. I redid that some 30 years later, and the percentage went up to 75%. I haven't done it since all the exome sequencing and the arrays came out, but I would suspect that it'll be even higher because of that. Particularly when you've done all your other testing and then you have one test like the exome sequencing left to do that lends itself to a diagnosis that you either didn't suspect or should have suspected. Examples would be the ectrodactyly, ectodermal clefting syndrome, and orofacial digital syndrome. The upper two pictures show the girl who's had a repaired cleft lip and a lobster claw or ectrodactyly hand. I believe she also had involvement of the feet. This pattern recurs frequently. The variability is not that great in this form of EC syndrome, so that when you find these two features and nothing else, and you can see she also has very sparse eyebrows and eyelashes, which is the ectodermal part, you can feel fairly secure in making the diagnosis. Unfortunately, as we get smarter, we have more things to know. And as you know, there's many EEC syndromes or ectodermal syndromes with limb abnormalities. And so we have to think about other things other than just the standard EEC syndrome in our differential. Orofacial digital. I'm not going to go through that, I'm afraid. We'll go back. Amniotic band sequence. I didn't define sequence, but it was on one of the slides before this. It's a abnormality of a particular area of the body that we don't know why it occurs, but it has a cascading effect on other parts of the body. And here you see the amniotic band is the basic definable abnormality in this patient. But we don't know why the band occurred. And everything we see, most everything we see after that, has or is related to the effects of the band and its constrictions. And so you can get a child who's missing the tip of one finger and have an amniotic band related adactyly, or a child like this that has so many severe defects. There's other sequences, and that's the Pierre-Robin sequence. And those of you who have handouts can see that the sequence is basically a defect like the small mandible in the Pierre-Robin that doesn't allow the tongue to stay forward or posterior, doesn't allow the ears to come up into the normal position, so they become low set. And so sequences or associations, how do I get to that? Sequences are a single defect, undefined, with cascading effects in other parts of the body. But they have a low frequency of being on a genetic basis. Associations are the non-random occurrence of anomalies. There's no consistent etiology associated with these associations. However, they do have 6 to 8 core features. These core features are usually major anomalies, not deformations or disruptions. But per individual patient may only have 3 to 4 of these. And that's why it becomes an exclusion diagnosis. You have to rule out other syndromes that have some of these features in order to come up with the association. Examples are Vater, Charge, which we'll go into, which is now considered a syndrome, and Merck syndrome. These particular disorders have 4 to 8 core features, and some of the patients will have about that number, 4 in particular, and you can recognize the pattern after you've excluded all the other syndromes that have that related pattern and have done your usually chromosome analysis to make sure it's not related to a chromosome defect. Here's a patient with Vater who has a missing finger up in the left, or hypoplastic finger, excuse me, and then an imperfect anus in the arrow below. These patients usually do not have a typical facial gestalt, and they're usually intellectually normal despite having multiple anomalies and other medical issues. The charge association, the gene for this was found on the 8q, and then it became a syndrome. I use associations a little bit differently because I think associations are a basket to put a group of features in if you don't know the etiology. You presume there is an etiology, you presume you eventually find it, when you find it, it becomes then a recognizable syndrome. Most people are smarter than me, so they figured even from the features in this particular association that it would end up being a syndrome based on those features. The coimatresia, you can see the necessity for tubes in the nose after they've had surgery in the left lower. He has stents. They do have very typical ears. Their facial features are not really very useful, except they often have facial weakness or paralysis. So that is a secondary effect of this condition, and that can be included, but they don't have that typical facial gestalt like you would see with Down syndrome and a number of other syndromes. A field defect. A single developmental defect is one that represents an embryological area where an error causes a major anomaly, which caused a major anomaly, which disturbs areas around it. Best examples of those would be the OEIS complex and uncomplicated whole prosencephaly. The OEIS complex, O stands for omphalocele, E exstrophy of the bladder, I for imperfect anus, S for spinal defects. That's all midline, which many of these field defects are. It occurs very early in blastogenesis, and it has a low association with other defects, although some patients can have other defects outside of the ones I just mentioned. And here's a group of patients. Only the one above on the left has an uncomplicated holoprosencephaly except for the microcephaly. The other two have chromosome abnormalities. The one in the upper right is trisomy 13. I might mention to you that notice the nose on trisomy 13, how thick it is. That's 100% feature in trisomy 13. So we often think of trisomy 13 with features like polydactyly, but that's only about half of the cases. So one of the things you want to do when you're looking at patients is you want to be sure you know the features that have the most frequent occurrence in that syndrome, because they can also be very useful in excluding or including the syndrome in your differential. Okay, the frequency of the feature in the specific syndrome, we've sort of talked about this in different ways as we talk about some of these other issues, but it's important to have features that have high frequencies to put your money on. If you want to bet on a feature, you want one that has a high frequency in that syndrome. For instance, axillary freckling in neurofibromatosis occurs in 80% of patients. I've never seen an NF patient that didn't have axillary freckling if that patient was a teenager or an adult. But this is one of these age-related frequencies that early on you might not see very many, but eventually you will see a large number. Broad thumbs and toes, 100% in Rubinstein tabes. When I was in training, Rubinstein tabes and Apperts were about the only two conditions that had broad thumbs and toes. So if you saw that, you had a diagnosis. Well, there's probably now 20 to 30 conditions that have broad thumbs and toes. And so we have to do a little bit more work. But it's still important. Rubinstein tabes, if you're making that diagnosis and there's not a broad thumb or toe, you better back off and see what you're actually looking at. We mentioned hypotonia, Down syndrome, 100%. Prenatal and postnatal reduction in stature in Russell Silver. We mentioned the bulbous nose in trisomy 13, and one of the most common features of trisomy 18 is the short sternum, even though the facial appearance is one of the first things that will allow you to suspect the diagnosis. Again, there's a whole group of other features we put together to make the diagnosis very solid, and you can do this at the bedside in 10 or 15 minutes. Here's a group of patients with rubicine TB. You can see the broad thumbs. They're also deviated. This is the syndrome that gave rise to the hitchhiker thumb term for a descriptor for their thumbs. They also have a high nasal bridge. The girl on the right looks typical. I call this the Danny Thomas syndrome. Those of you who are young don't remember Danny Thomas. He's the one who started St. Jude's. He was a comedian. Marlo Thomas is his daughter. She looks much better than he did. And but sometimes I attach facial features to famous people. Makes me remember them. I've got to talk on that. I'm going to give you some time. Prioritizing features. And it's based on the rarity of the feature. For instance, low set ears, 1 in every 25 people have that. Useless. You might not even write it down. And it's almost always secondary as well. VSD, or ventricular septal defect, has some usefulness, but not really very much. Cleft lip, remember the high association with other defects elsewhere. You start to feel there's some money in that feature. Coimatresia, 1 in 10,000, that is a very useful feature. In fact, I described the syndrome many years ago by taking only patients who had coimatresia and looking at all their features and deciding if there was a recurring pattern, which there was. And one of the bases of how I diagnose patients is to do the statistics, find out what is the most rare feature of the syndrome. It will not, if you're going to do research on this syndrome, it will help you reduce the number of disorders that you have to consider. Anophthalmia, again, useful. Tongue hamartomas, even more useful. And there are other features that are even more useful. So prioritize the features you see and try to keep in mind which one is useful and which ones aren't. There's orofacial digital. You see those areas in the mouth that look fleshy? Those are tongue hamartomas. Outside of the orofacial digital syndromes, which there may be upwards of 10, it's very rare to find them in other conditions. And when you do find them in other conditions, they're frequently related to the same pathway that the orofacial digital syndrome occurs. Polydactyly is almost always preaxial, but not always. So know when you can expect variability in a particular feature in this location, particularly when some syndromes will have all postaxial, some will have all preaxial, a few will have central, and you need to be aware of that when you're giving weight to the feature. Here's some that we talked about, the tongue hamartoma, but these are conditions in which the observation of the feature will immediately result in a diagnosis or a very, very short differential, because they are individually rare, and I've marked with yellow asterisks the ones that are pathognomonic. You can take them to the bank and you can make a diagnosis. And I'll show you a few of those. Here's a child with a branchiootofacial syndrome. It has plenty of other features, and unfortunately it's variable. But what's not variable is the reddish mark behind the ear. This used to be thought to be hemangiomas, but it's ectopic thymic tissue. And so that was what allowed me to make the diagnosis of the second case of this disorder and the third case of this disorder, because of that red lesion behind the ear. And everything else just fell into place. Trophic Dysplasia is one of the skeletal dysplasias that has a number of features that would allow you to make the diagnosis. But the cystic ear, as you see in the upper left center in both pictures, can occur prenatally and go away, but leave a crumpled ear, or it can occur up to 2 months postnatally. But it is not found in any other conditions except for boxers who get hit in the ear and they can get swelling and they can get cystic ears and some of the same complications these children have. Dystrophic, by the way, means twisted. They will develop scoliosis, which is usually not present at birth. Subtyping features. Cleft lip, unilateral, bilateral, midline. Which one gives you the most information as far as syndrome diagnosis? The midline, because it's the rarest. The polydactyly, the central polydactyly, you can see, is the rarest and only has a few differential diagnoses to consider. And then short stature. Half the patients with chromosome problems have short stature. So unless it's extreme, it's not very useful. But when it becomes disproportionate, it becomes much more useful. And when it's disproportionate, most of those cases are going to be skeletal dysplasias with disproportionate growth of the spine and or limbs. And then you can even subdivide disproportionate into forms. Mesomelic means the middle portion of the limb. If that limb is extra short, then there's relatively few disorders that have that as a feature in the skeletal dysplasias. So that becomes a very useful feature. And this is a girl who has langular mesomelic dysplasia, has extreme shortness of the radius and ulna. You can see that. And there's a milder form of this called dyscondylosis of Leary and Wheel, in which it's much milder, but still very useful. And so pay attention to proportions. And when you see disproportion, that's not a negative, that's a positive, because that gets you into a much smaller differential. And then if you can subdivide that shortness into certain segments of the body, trunk, mesomelia, rhizomelia, acromelia, then you can, again, you've got a muddy situation there for diagnosis. Additive features. We have a patient with short stature. We've determined it's disproportionate. And that patient has postaxial and has multiple frenuli. So we know that that patient most likely has orofacial digital or one of the syndromes that are similar. In this case, Ellis Van Creveld is the particular disorder. If we could also put in here a large single atrium, which they also have, to add more useful features. So the major feature you see in the patient may not stand alone, but if you add the other features, and you usually don't take many, you can get into a very positive diagnostic place. Here's a girl and a number of kids with Ellis Van Creveld. You can see the frenuli of the lip there attaching to the gums. You can see the ectodermal part of this with conical teeth. You can see the chest is small. You can see the polydactyly that is found in the majority of these patients. This is a recessive. And the extreme severity, we can take all the things we talked about and have a group of features that really aren't very useful. Remember I said short stature is found in half of patients with chromosome problems? But what if they are extremely short? Particularly if they're prenatally extremely short. That has added value to the features that you're looking for. Because frankly, there's not a lot of extremely small fetuses that get to term and are still extremely small. You can bet they're going to stay small. But that's a good category because you can take that and look up patients with fetal growth deficiency and find those that are extreme, and then you have a very short differential. Microcephaly, if it's extreme, it's very useful. If it's mild, it's usually not useful at all. Moderate, sort of in between, but extreme will help you. Single atrium and Ellis Van Creveld. Those patients with extreme micronathia, which is common in a number of syndromes, not extreme, but micronathia, then you have a relatively small number of conditions to consider. If anybody can tell me what this patient has, I appreciate it because he's extremely short, prenatally, postnatally, but has very distinctive features, a lot of major anomalies. I've never been able to diagnose him. So please help me, as they say in Kentucky. Marker feature. What if you don't know what the patient has? You didn't see it initially. Your tests so far have been negative, and you want to follow the patient up, which is always good, and particularly in an unknown condition. And then suddenly you see something that wasn't there before or that you didn't notice. More often than not, that particular feature is going to be very important to the ultimate diagnosis. And occasionally it even results in immediate diagnosis. On some instances, and I'm not including chromosomes or exome sequencing, a lab finding or a medical symptom may be a marker feature that make you think of a syndrome that you didn't think of before. Here's a syndrome called Mendenhall syndrome, which is a hypersensitivity to insensitivity to insulin. On the left, I saw this patient as a newborn. He looked coarse. I thought he had potentially a metabolic condition. But I didn't know because the bones were normal, there's no visceromegaly, and all the testing was normal. But in time, he became more coarse, developed this very characteristic face, but more importantly, he started to develop acanthosis nigricans, this dark skin around the neck and in the axilla. And that told us that he had an insulin problem, too much insulin. And the syndrome that matches the face and that finding is Mendenhall. Other important aspects, we know these patients are dysmorphic. Many of them form patterns, but we don't recognize them. But these, particularly the secondary features, the deformations, but not so much the disruptions, will change with growth and age and maturation. And so it's very important to know what that patient looked like as a child. Very important to know what that patient's siblings look like as children. Very important to know what the parents look like at the same age as the patient you're seeing, their daughter or son. So follow-up and getting all that information is extremely important, and you all are well aware of that, and having them come back periodically for lots of reasons we've already discussed. The woman on your left brought her child in because he was deaf. He also had some different colored irises or irides, and we thought he had Waardenburg syndrome. But there's no family history of Waardenburg syndrome in the family. The mother wanted more children. We did note that she did have a rather prominent nasal tip, but her hearing was normal. She didn't have a white forelock. Her irides were normal, dark actually. And so we said, well, can we see some pictures of you when you were a child? And this is her on the right. So the very flat nasal bridge and the dystopia canthorum, which is also typical for Waardenburg syndrome, but she didn't have those features at the time we saw her. And to finish up, and remember I did this talk in 2000, I put this talk together in 2013 and gave it the first time in 2014. So in this era of fast changing things, there's been a lot of changes since I developed this particular talk. But the type of testing that we normally do, and you can see all this here, has resulted in very accurately diagnosing a number of conditions that we could not diagnose before or misdiagnosed before. However, the bedside clinical diagnosis is still fast, usually. It's certainly cheaper initially. And you can test for a specific diagnosis if you suspect it. That may result in early or appropriate therapy if there is. But additional testing may be required, which can prolong confirmation of the diagnosis. You have to remember that a number of years ago, like 40, we didn't have hardly any tests. So it was all based on clinical recognition of the phenotype of the patient. Here's a patient I followed for years on the left with Noonan-like syndrome. The only thing that he was different in was the fact that he had a large head and he had this unusual hair that didn't develop initially, but was present by the age of 2. He had a pectus excavatum. Someone discovered a shock 2 defect, the hair being the giveaway, very abnormal anagen hair, as it said. And so the follow-up for him took some 12 years before he came up with a diagnosis. But the mother never gave up on me, and I was always irritated that I couldn't make a diagnosis that, based on the literatures. Genomic diagnosis can be slow, can be expensive if you can get it paid for. So a lot of the things that go on here, you don't quite feel it the same way as a lot of other places do. You don't have an in-house unit to bear the expense of these testing. It is a shotgun single test. Most of the testing we used to do was aimed at a particular abnormality, although not constantly. So anytime you get shotgun testing, the mind starts to deteriorate because you're not thinking as much about the patient and what you're seeing and what you're observing. Because of the delay, initial therapy may be delayed, but difficult cases are often diagnosed that we couldn't have diagnosed any other way at this point in time. And those conditions in which there is a family or a pathway of phenotype that's somewhat similar but occasionally dissimilar is more easily identified. This is a good example of by matching up phenotype with famous people. This is from The Simpsons. The girl at the top is the voice of the mother in The Simpsons. I noted many years ago this rare syndrome called the Schellbach-Rott syndrome had the features you see in this young lady. Thought that she was very similar to the actress who's done more than voiceover. She's done quite a bit. And then someone called me up one day and wanted me to see one of their friends' sons. And we did, and in fact, he has the same phenotype. They all have a very high-pitched voice, which she uses to great advantage in some of her movies as well as The Simpsons. And here's another example of the use of the exome sequencing and the array. This patient here I followed for many years as a Congenital on the left, but he turned out to have the Nicholas-Baraitser syndrome, which is in the same pathway as Congenital, and they're very difficult to tell apart, except the Nicolaides-Baraitser syndrome does not usually have missing nails. And this is just another example of a group of what appear to be discordant syndromes that are the mutations due to mutations in the same gene. We call these family syndromes or pathway syndromes. Here's a patient with Kabuki. Not sure why I put him in there, except that we diagnosed him long before the positive testing was done. Problems with exome sequencing, potential lessening of clinical skills. I don't think there's any question that that will happen, and is happening. And those people who it's happening to are going to be teaching the next generation. It's going to get worse. So I don't know. There's no answer to this. I love exome sequencing. I'd love to be able to do it on every patient I ever saw because I have a whole slew of ones that need it. It should be ordered with due diligence toward differential diagnosis, but when you're doing exome sequencing, it's usually not that. Interpretation of results can be problematic, but as we go on, it's getting better and better. And this is an old slide. Obviously, exome sequencing identifies no more than 30% of mutations, but in the best selected patients, it can be up to 50+%. Value of a dysmorphologist, that's me. That's someone who just eats and sleeps this particular phenotypic analysis. I can certainly aid with the clinical diagnosis at the bedside because of the conditions that we see and the experience that you've had in the past. You may be able to be a sounding board for potential therapy, and you can suggest more tests other than just the exome sequencing that may end up with a diagnosis. The interpretation of the test results when needed would probably be me, but some dysmorphologists are very good with molecular aspects of genetics and would be excellent to interpret the results. The genetic counseling prognosis I can do if I've had any experience with the conditions. Some of the conditions I've had a lot of experience with because I've been doing this for 40+ years. and that helps a lot. And sometimes you can take a condition that you don't know much about and see the symptoms and make a very good educated guess as to what those symptoms refer to and prognosticate on those. Always establish long-term follow-up. It's the thing that will tell you whether you're right or wrong and give the parents a chance to adjust and the child a chance to tell you where you're wrong, because a lot of them will tell you. They don't read the same books that we read. And then I can always notify the family when there's a new testing or test that becomes available. And so that's a little bit, I think, around over 4 minutes. If you have any questions or comments, please let me know, and I'm glad to answer them. It's 5 after 1. Okay.